All right. Good afternoon, ladies and gentlemen. Am I being heard? Are you hearing me? Okay, thank you very much.
Yes. Yes, we do hear you.
Thank you very much. I think for now, so that we can have an uninterrupted meeting, I will advise that you unmute yourselves, that everybody should unmute. Sorry, you should mute yourself rather. Mute your microphone so that we can have only one person talking at the same time. So once again, good afternoon all. You are welcome to this webinar. First of all, maybe we should say welcome to World Glaucoma Week. As you are aware, this is our World Glaucoma Week and activities have been taking place in various centers. ISTH has not been an exception. And we have had to do a lot of things. Later on, the HOD will talk to us and let us know the part that what ISTH has done as regard World Glaucoma Week. But this afternoon, the responsibility I'm saddled with is to anchor this webinar, which is a part of the World Glaucoma Week. So this afternoon, we'll be having some eminent personnel from various fields in the eye profession talk to us, including a pharmacist who deals with eye medications also. They'll be talking to us. We'll try and stick with the better side of 1 hour, as each presenter will be expected to speak for about 10 minutes, or maybe a little bit less or a little bit more. And we hope to wrap this all up by sometime around 3 o'clock. But before I introduce the presenters, I'd like to, first of all, thank the Chief Medical Director of Irrua Specialist Teaching Hospital, who has graciously supported us enormously for this year World Glaucoma Day. I think I will leave the other part for the HOD to say when she comes up to talk to us as regard what we have been doing in ISTH and all the assistance we've gotten from both the management of ISTH and some other drug companies. But let me go to my own assignment right away. This afternoon we'll be talking on glaucoma. We have 5 very important people, 5 professionals from various professions in the eye, various areas in the eye profession to speak to us today. First, we'll be listening to Dr. Basui. Dr. Basui is a consultant ophthalmologist and an ophthalmic surgeon with ISTH. He has a lot of interest in glaucoma and has been our anchor person in the glaucoma unit in the hospital. Dr. Basui, you are welcome. The other person that will be talking to us is Dr. Sadiq Abdullahi. Dr. Sadiq Abdullahi is a glaucoma surgeon from National Eye Center, Kaduna. Incidentally, Dr. Sadiq Abdullahi is my very close pal. We're flatmates at Isfahani in Bangladesh when he was.
Once a chief, always a chief.
What? What did you say?
Yes.
Yeah, he was my
chief now.
Yeah, he was my flatmate back in Dhaka, Bangladesh, when we were undertaking our subspecialty. I was in retina and he was in glaucoma. And not just was he my classmate, was my flatmate, was my main pal. We went through all the problems of being in a foreign land together, trying to exploit and give ourselves some level of fun while training at the same time. Can I assure you, I know the interest that Sadiq has in glaucoma, and I can assure you he's going to do justice to the topic he's been given to speak with. The other person that we talked to is Dr. Irrua Ijegede. Dr. Irrua Ijegede is a principal optometrist with Irrua Specialist Teaching Hospital. He's been on ground for quite a while. A very dedicated optometrist who has great interest in low vision. As you are aware, the final place for glaucoma patients when they present very late, that we have to try and rehabilitate them. So Dr. Ijegede will be talking to us on the areas of low vision. Then we also have, because we want to make it an all-encompassing discussion, we also have our head of unit, an assistant director of nursing, and an ophthalmic nurse also, who will be talking to us also, Mrs. Philomena Ahamioje. She's been on ground for a long time too, a very dedicated member of staff with Irrua Specialist Teaching Hospital, and she will be talking to us nursing care of the patient with low vision. She's a very experienced nursing officer and has been there and has been talking to people in this area, and I'm sure will benefit largely from her. Last but by all means not the least, we'll also be listening to management of glaucoma, the Microsoft approach by Micronova Pharmaceuticals. They've been of great assistance to us, especially in the areas of indigent patients. They've given us drugs severally to help indigent patients, and I think they have a lot to tell us also. So before we kick off, I'll just call on the HOD to make a small remark, and we'll go straight to the topic of the day. HOD, Dr. Miss Alika. She is actually the person that put all of this together, and she's got quite a lot of passion for ophthalmology first and glaucoma in general. She has an interest in community ophthalmology, and she's been in the department for a while. HOD.
Thank you very much, Dr. Wilson Overia. I want to start by thanking our Chief Medical Director, Professor Silvanus Okogbeni, for his unrelenting support to the ophthalmology department. He has done a lot to develop eye care in ISTH, and he has been a constant pillar anytime we call upon him when we are doing any of our programs, both for the World Glaucoma Week and in celebrating the World Sight Day in the past couple of years. For this year, he granted us permission to have a 50% discount on the OCT, which we recently acquired. And it has been of tremendous help and benefit to our glaucoma patients, who, a large proportion of whom are indigent. And I want to also thank Micronova Pharmaceuticals. They have been of immense support in helping the indigent patients. The drug donations they gave and the banners for publicity have really gone a long way in the celebration of the World Glaucoma Week in ISTH. I want to also thank Altines Pharmaceuticals and also Dotemag industries. They also contributed drugs. And also the Irrua Specialist Teaching Hospital Management, who gave drugs, who supplied drugs for us to give for free to our indigent patients. So overall, it has been a very successful week. Of course, I can't end without thanking in a very special way my ophthalmology family, as I call everyone. Without that teamwork, an outreach is an impossible task. Everybody has been on their feet, starting from the porter, Jacob, the cleaners, right up to the consultants and our professor, Professor Enoch, our elders, Dr. Kadiri. I mean, they have been of tremendous support. They have been on their feet along with the younger doctors, optometrists, nurses. Nobody was left out. In fact, the team has been up and doing. And I want to thank you all for that tremendous effort you're making in the lives of patients, both indigent and otherwise. So we hope to have a successful webinar, and the link will be put up, the YouTube link. So even after the live broadcast, if you wish to go and educate yourself, you can just go to YouTube and also listen to the presenters once more in case you missed anything. And you were always available to answer questions, both here and otherwise. Thank you very much, Wilson. Over to you.
Thank you very much, HOD. You actually just made this whole thing work. I know at the planning stage, we were looking at the possibility, especially with the new way of life we have to adopt because of the COVID-19, but you never gave up. Some of us, we've always enjoyed World Glaucoma Week and other weeks as relates sight, but you actually made this work, and we're happy that we did not give up, and we also worked with you even in the face of difficulties. Without wasting more time, let's go straight to the program of the day. I'll call on our first presenter, Dr. Cyril Obasui, who, like I said before, is a consultant ophthalmologist with Irrua Specialist Teaching Hospital with glaucoma interest. I call him my main pal because we share the same unit incidentally. And sometime when I get lousy, I remind him that I'm older than him, both in age and in the profession. I get him to do work. Today, I get tired and I have to run away. I will make him do extra work. Yeah, he has not denied that he's my boy. So I will continue to enjoy that until he proves to be my boy. Dr. Obasui will be presenting an overview of glaucoma. He's an eloquent speaker, and I'm sure you will enjoy the presentation. Dr. Obasui, could you share your screen now? And it's your time.
Yeah, thank you very much, sir. I know I'm your boy. I have never hidden that fact. Like Sadiq said, once a chief, you're always a chief. Let me take this chance to welcome Dr. Abdullahi Sadiq. Dr. Sadiq has brought his wealth of knowledge to us in the YOF too, and I'm happy that he's with us here, and I'm very sure we'll enjoy Dr. Sadiq's presentation. Dr. Vera, sir, you need to enable participant screen share. It's not been enabled yet.
Okay, sorry. All right, I think that's okay now.
Okay. Oh, yes, it is. Thank you very much, sir. Okay. Let's get it set up. Okay, so I have been given the opportunity to discuss an overview of glaucoma with the Irrua Specialist Teaching Hospital and members of the public who would join us as we continue. And I have 10 minutes to do justice to this Herculean task. So I'm going to try as much as possible to do as much as I can within the short time that I have. So the question is, what is glaucoma and how does glaucoma happen? This is what we're talking about. I'm going to try as much as possible to get you to let us know what glaucoma is. I'm going to try as much to tell us how glaucoma happens, and then give us an idea of the burden of glaucoma in Nigeria. And then for those of us who are not ophthalmologists, I'm sure we would love to know how to know if we have glaucoma. And then we've been told we have glaucoma. What do we do? So I'm going to try and do this in 10 minutes. And I'm hopeful that I'm able to do justice to the presentation. So what is glaucoma? That's the question. What is glaucoma? I have a video up there to help.
Light rays enter the eye through the cornea, pupil, and iris. These light rays are focused on the retina, light-sensitive tissue lining the back of the eye. The retina sends signals through the optic nerve to the brain. These signals become the images we see.
Yeah, so that was just a little video to give us an idea of what glaucoma the eye is. Like the video showed us, the video tells us that there are different parts of the eye, of which the optic nerve is the main part that takes information from the environment to the brain. Glaucoma damages the optic nerve. From the video which is playing at the background, you can see the optic nerve being highlighted at this point. That is the optic nerve. This is the optic nerve, and this is responsible for taking information from the environment to the brain. And the optic nerve is what's damaged in glaucoma. And apart from damaging the optic nerve, glaucoma reduces the visual fields. If we take a look at my picture, which I'm showing here, you can see that at the early stages of this patient's disease, at this point, you can see that this patient sees this pedestrian and this vehicle at his periphery. As glaucoma progresses, the visual fields are damaged from the sides. This is the same patient. You can see the damage has progressed, and the patient no longer sees the pedestrian or the vehicle. The pedestrian and the vehicle were not magically transported to another planet. They are there, but the patient still can't see them no longer because of glaucoma damage to the optic nerve. But the vehicle in front of him is still as distinct as ever. So glaucoma is a disease that damages the optic nerve, causing reduction in visual field, and ultimately leads to blindness. That is glaucoma in a nutshell. Damages the optic nerve, causes a reduction in the visual fields, and ultimately leads to blindness. So, how does glaucoma occur? Glaucoma can be said to occur. Just watch this video and you know how glaucoma occurs. So, that is how glaucoma happens. So, excuse me. The drainage angles are responsible for draining aqueous humor out of the eye. Aqueous humor is produced at all times. The aqueous humor is produced at this point and then travels to the front of the eye where they are drained into the collector channels all around the eye. When these drainage angles are blocked or drainage does not occur properly for whatever reason, then we know then glaucoma is set to happen. Sorry, excuse me. Sorry, my slides are acting up. Come on. Okay. So the drainage angle are located at these points, and most times we have structures growing to block the drainage angle. The drains don't work as much as they should do. or the angles are so narrow that aqueous isn't drained as much as it's supposed to be drained. As this happens, the intraocular pressure builds up because there's continuous production of aqueous, and this aqueous remains in the eye, and the pressure is directed backwards, and that pressure damages the optic nerve, and that is, in simple terms, how glaucoma happens. Now, what is the burden of glaucoma? From the 2015 blindness impact survey done to the Nigerian National Blindness Survey, it was found that a lot of people in Nigeria have got glaucoma. And the figures are 1 in 20 people over 40 years and older has glaucoma. And of these people who have glaucoma, almost all of them are not even aware that they have glaucoma. And even those who have been told they have glaucoma, at the time of diagnosis, 1 in 5 are blind. So those figures are scary. Those figures tell us that 1, glaucoma is all over Nigeria. 2, even though glaucoma is so much in Nigeria, a lot of us don't know that glaucoma is available, is around in Nigeria. And that's the reason for lectures like this. Lectures like this are supposed to get the public to know that there's glaucoma. Glaucoma is dangerous, a silent thief of sight, and we need to do something about it. How do we know we have glaucoma? Well, first of all, what are the risk factors? If you are 40 years and older, if there's a family member of yours with glaucoma, if you belong to the African race, you're an Asian or a Latino or Hispanic, if you've used steroid drugs for a very long time, or you had a past eye injury or surgery, you are at risk for glaucoma. Now, we keep saying at risk because there are no signs or symptoms from glaucoma. The only way you can know you have glaucoma is by checking your eyes. The only way you can prevent glaucoma from happening is by checking your eyes. So if you fall under these risk categories, please do well to check your eyes at least once a year. And that is because blindness from glaucoma is irreversible but preventable by early diagnosis and care. And early detection and prompt treatment can make the difference between a bright future and blindness. So now that you've gone to check your eyes and you know you've got glaucoma, so what do you do? First of all, no worries. You do not have to be worried. You do not have to be scared. There is no issues because glaucoma can be properly managed. It's been shown that people with glaucoma, when properly cared for, 80% of them will die with good vision intact. So whatever vision you've got when glaucoma is detected can be managed, and you can have good quality of life even after diagnosis. Just get checked on time so it can be detected early. Now you've been told you've got glaucoma. Do not be worried. Glaucoma can be managed, and your doctor, your ophthalmologist, will choose the best form of care for you. This care is individualized and tailored to the patient. Could be in form of medications, in form of lasers, surgeries, or both. But remember, glaucoma care is lifelong. Lifelong, no off days. So you must adhere to your doctor's care plan to make sure your vision remains good and useful for you till you are called yonder. Thank you very much. Dr. Vera, over to you, sir. And I think your microphone is mute.
Oh, Dr. Masu, thank you very much. That was real fast and straight to the point and very educative. I think your presentation is what I can best describe as bread and butter presentation with those lovely videos and the pictorial demonstration. You obviously did justice to the topic. Thank you very much. I will advise everyone with us to note down the questions so that we'll take all the presentation and hit the questions right away after the presentation. So we'll call on the next presenter, whom I've introduced earlier, Dr. Abdullahi Sadiq, who is a glaucoma surgeon with National Eye Center, Kaduna. He will be talking to us on glaucoma in children. Dr. Sadiq, over to you, please. Dr. Sadiq? Dr. Sadiq, can you unmute yourself?
Okay. Thank you very much, my chief, and Dr. Wilson. has always been my chief.
Dr. Sadiq, I'm not sure we are hearing you clearly.
Please take us out.
You're doing very well.
I'm sure if I mention Bushan, can you hear me?
No, Dr. Sadiq, we are not hearing you.
Okay. Can you hear me now?
Okay, I think it's a lot better now, but you will start all over again because we aren't hearing at all.
Okay. Let me start sharing again.
Okay.
All right. Can you hear me now?
We can hear you quite better now.
Oh, thank you. Dr. Wilson has always been my chief, and when we are in Bangladesh, he used to take us out. I'm sure if I mention Bushandara, you know what I'm talking about. And Dr. Cyril also has already made a very elaborate introduction about glaucoma. So that will really make my presentation quite easy. So I'm going to talk about glaucoma in children. I'm Abdullah Siddiq Mohammed. I work for National Eye Center, Kaduna. So, but before I start my presentation, we need to define who is a child. A child depends on the country you're talking about. In the United States, a child is somebody who is less than 18 years. Well, in UK, Europe, and according to UNICEF, someone who is less than childhood glaucoma. You're talking about glaucoma in someone who is within that age bracket, either 18 years if you're in the US or 16 years. But I don't know in Nigeria. Really, I don't know who is a child in Nigeria. But these are the international definition. Now, there's a definition of glaucoma by Childhood Glaucoma Research Network. They define glaucoma in a child when you have two or more of the following that I have shown in the slides. Now, the first one is IOP greater than 21. Usually, glaucoma in children, people don't take about pressure very high. Normal pressure is between 10 to 21, but there's an argument that whether normal pressure in adults is the same as normal pressure in children. So, therefore, when diagnosing glaucoma in a child, they don't really take IOP more of importance, but they consider more of other changes that could result from high pressure in a child's eye. And those one like enlargement of the child, enlargement of the eye, like this one has some corneal changes. I don't know how to present this because there are other non-ophthalmologists, and I believe the presentation about creating awareness is not of a clinical presentation. So this one, when you have two of these in a child, that is when you see the child has glaucoma. One, when you have IOP greater than 21, or when you have cup-Dix ratio plus cup-Dix ratio, and other findings that are suggestive of glaucoma. When you have two in somebody that is less than 16 or less than 18 years, you can make a diagnosis of glaucoma. When you have corneal changes, some signs on the cornea, like this, I have some pictures that I will show later. Now, glaucoma in children can be divided into two. We have what we call primary childhood glaucoma, and then we have what we call secondary childhood glaucoma. In primary glaucoma, we have, it's of two types. We have primary congenital glaucoma, and then we have juvenile open-angle glaucoma. The difference between the two is that in one, there are changes in the eyeball structure as a result of persistent elevation of intraocular pressure. That is in primary congenital glaucoma. Where in the other one, there is no change in the structure of the eye. It's just like in adults, but the person has glaucoma. Now, the second type of glaucoma that you can see in children is called secondary glaucoma. Glaucoma may be associated with non-acquired ocular condition. Non-acquired ocular condition means there's some defect that might be present at birth that are restricted to the eye. Or sometimes there might be some systemic disease that the child is born with, and in addition, the child has glaucoma. So you can have glaucoma with birth defect of the eye, or you can have glaucoma with systemic disease, which are all present at birth. So that is glaucoma associated with non-acquired ocular anomalies. With acquired condition. For example, a child can have trauma and develop glaucoma. A child can use steroids and develop glaucoma. That will subsequently lead him having a glaucoma. Now, the third one is following cataract surgery. One of the commonest complications of childhood cataract surgery is glaucoma. So this is how glaucoma in children is classified according to childhood glaucoma group. And this is the commonest, this is the primary congenital glaucoma, the one I was talking about earlier. In this one, it can be present at birth. That's called a newborn within the first 1 month of life. A child can manifest signs of glaucoma. Or it can be diagnosed between 1 month to 2 years, or it can be late onset, more than 2 years. And of course, this is a very rare disease. We see them rarely 1 in 10,000 to 30,000 people. Is diagnosed 60% at the age of 6 months before the first year of life. And of course, it's more common in males than females. And it's usually bilateral. It affects the both eyes in 70% of the cases. There's some inheritance. If one of the family member has it, there is possibility that another member of the family might have the disease. And we don't know the exact cause of the primary congenital glaucoma, but some people believe that there is like a membrane that covers the drainage side of the eye. And as a result of that, aqueous cannot exit the eye, and therefore it leads to accumulation of the aqueous and subsequent elevation of intraocular pressure. But to date, nobody has seen this membrane, but that is one of the accepted pathophysiology of primary agricultural glaucoma. So a child with congenital glaucoma, how do they present? What is their complaint? How will you know that this one has congenital glaucoma? So these are the 3 triads that everybody knows: the epipora, photophobia, and blepharospasm. When a child is staring and always close the eye, when you have these 3 things as signs of possible congenital glaucoma. And of course, they tend to have a large eyeball, and the cornea become white. They have decreased vision, sometimes cataract formation. This is one of the patients I saw recently, just like last week also, that presented with congenital. You can see the eye is looking larger than normal. People will say the guy has bulgy eye, but it's actually congenital glaucoma. If you can see, this eye is appearing whiter than this one, becoming opaque. So this is the eye that is more affected than this one. Now this is a lady who has congenital glaucoma, and we operated on her. Now this is how this is one of the eyes of the first patient that I show. You can see these are some of the changes that can happen to the eye as a result of persistent elevation in intraocular pressure, and the eye become larger. So when you see a child with large eyeball and the eye is becoming whiter as against being black, then that is a possible sign that the child is having glaucoma, more especially when the child is excessively tearing and there is associated a pair of lights, and then the child is closing the eye. When you have these 3 things in the setting of this eye, there is every possibility that the child has glaucoma. It is a white Caucasian eye, you can see. Sometimes you can have complications like this. Okay, but this one are infant and children. This one are infant and babies I'm thinking about. But remember, I'm thinking about glaucoma in children, and a child is somebody less than 15 years. So somebody can have another type of glaucoma that is not primary congenital glaucoma. For example, a child can have juvenile open-angle glaucoma, which is defined as glaucoma from 3 years up to 35 years. But for childhood, we consider those that are less than, so the eyes may be apparently normal. There may not be any enlargement. There may not be any tearing. There may not be any other things apart from the usual signs of glaucoma. And those types of glaucoma is usually more, they have high pressure, it progresses faster, and unfortunately, in most of the time, it doesn't respond to conventional medical treatment. And most of them, they end up surgery. A child will not allow you to examine him thoroughly. Sometimes everything has to be done in the theater. The child has to be put to sleep. And this is examination under anesthesia. You have to put the child to sleep, check IOP, take some measurement and other things. And this is what the nerve of somebody that has glaucoma looks like. And so because in glaucoma, in children, the eye wall is not fully developed, it's immature. Any elevation of the intraocular pressure the iris.
Okay, he's back. Dr. Sadiq, it's like we lost you for a while. It's trying to catch up. Pictures are on. Dr. Sadiq. Dr. Sadiq.
Can you hear me?
We lost for a while, but you're back on now, so you can continue. Let's see if we can keep hearing you.
Okay, but can you hear me? Did you hear when I talk about juvenile open-angle glaucoma?
Yes, we heard that.
Okay, so that's good. Okay, now that's where I was before. So I'm thinking about some of the structural changes that can happen on eye that has congenital glaucoma, and that are actually proxies of chronic IOP elevation. So sometimes even if eye pressure is normal, but you are seeing those other structural changes in the eye are increasing, it means that pressure is not normal for that eye. And that is why it needs to be monitored consistently. So it's not everything here that is, it's not every tearing and photopolia that is glaucoma. There are other things that need to be ruled out before we make diagnosis of glaucoma. And all these are some of the conditions that are not glaucoma that can explain a large eyeball and other things. And even corneal clouding, there are other conditions that can explain it that is actually not glaucoma. So because, a child, before you subject him to the surgery, to the treatment, you have to be sure that it's actually glaucoma that you are dealing with. And these are some other things that I can explain. Now, treatment for congenital glaucoma or childhood glaucoma depends on the type of glaucoma you are dealing with. So the first thing is to establish the glaucoma diagnosis correctly. Is it primary congenital glaucoma? Is it secondary childhood associated with other ocular or systemic anomalies? Or is it a glaucoma following surgery? But whatever type of glaucoma you are dealing with, the most important thing is early diagnosis and prompt appropriate treatments. And these are the various treatment options: goniotomy, trabeculotomy, trabeculectomy, and then in a very bad case, you can do cyclophotocoagulation. I'm not going to take much of your time on this. These are all the surgical. Then sometimes you like to start patient on drugs in preparation for surgery. And these are some of the eye drops that can be used before definitive treatment is provided. Now, so these are some of the complications: amblyopia, lazy eye, and some strabismus. So I'm trying to rush it because of time. And so in conclusion, childhood glaucoma is a big problem. It's a glaucoma that is difficult to treat, but it's with us and we need to create awareness about it. Thank you very much. And this is where I'm going to stop.
Thank you very much, Dr. Sadiq. I can understand your constraints. You are embodiment of the human knowledge, and I know that 10 minutes is much too small for you to share what you have to share, but I can assure you that you've given us a very good overview of childhood glaucoma, and you actually refreshed our memory and went ahead to tell us some new things that we have been wondering about. I'm sure there are a lot of questions for you. I already have a question for you, but we'll wait till the end of the presentation. Once again, thank you very much. You are our guest presenter, so we are honored to have you. And we're actually allowed in some extra time because we cannot be giving you the same time as all other presenters.
I feel honored to be here.
Thank you very much for giving us your time, but please stay with us because we definitely have questions.
Certainly, I'm with you, sir. I'm with you, sir. Thank you, sir. Let me stop sharing.
Thank you very much. The next presenter is right here with me, Dr. Ijegede. He had to come and take coffee with me before we started the presentation, before we started the whole show. He's going to be talking on, sorry, just 1 minute. Let me do a screen share. Okay, sure. Good. So Dr. Ijegede is going to be talking to us on low vision in glaucoma. Are we seeing the screen now?
Yes, yes, we can see it.
Thank you very much. Dr. Ijegede will be talking to us on low vision aid as pertaining to glaucoma patients. So Dr. Ijegede, over to you.
Good afternoon, everyone. I'll be talking on low vision aids. So we are going to follow this outline: definition of low vision, what is low vision aids, basic principles of low vision aids, types of low vision aids, how to prescribe low vision aids. Then we'll also conclude. What is low vision? A person with low vision is one who has visual impairment. So what we should take in this definition is that there is a but the patient is still has potentials of also using the vision for planning or execution of tasks. Low vision aids could be an optical
Okay, thank you very much, everybody. I think we may have lost Dr. Ovira to some technical difficulties. And so I think while we wait for him to set up and resume, I think we want to call on Sister Ayameoje to start her own presentation on nursing care for the visually challenged. Then we hope that Ovira is able to sort his technical difficulties so that he can join us as soon as possible.
I'm actually back.
Okay, I think he's back.
I'm back, but I think they have taken me with you because the other Zoom is subscribed.
We can't hear you, sir.
It's like I'm now on YouTube. I'm joining on through YouTube because
but you will be unable to present via YouTube.
Can you hear me now? Let me see.
Yeah, we can hear you, but there's a lot of interference.
Yeah, I guess so. There's no space for me to join via Zoom.
Zoom, we are on Zoom already.
I'm on Zoom already.
Yeah, you're on Zoom, but I think your network is a little bit catchy.
Okay, so okay, but you are admin now.
Yes, I am.
Okay. So I think what we'll
network is what? See, the showing range.
Yeah.
let
So I think let her start her nursing care of the visually challenged, while Dr. Ovira still tries to sort his the network challenges out.
Exactly. Thank you very much.
Okay, so Matron, please, over to you. You need to unmute. Okay, fine. Your microphone is better now.
Yes, I've done that. Good afternoon, everybody. I am Ahameje Philomena, as introduced by Dr. Vera and
Matron, I think you have two devices.
Yes.
You have two devices on. So there's going to be a lot of, yes, you have two devices logged onto the webinar.
Yeah. Okay.
You could put one on mute so that
wait,
the feedback is less.
Okay, I have two devices on. Where are they?
Yeah. There's a feedback. There's a device that's logged onto the meeting too close to you. So the feedback is okay, but you're better now. It's better now.
Am I better now?
Yes, this is much better.
Okay, I should. Is it better now?
Yeah, this is much better. Thank you very much.
My work is out. So okay, let me get it back. Sorry, my work is out. Hope I didn't delete my job. Presentation PPT.
Maybe I should get it to come back.
And so I think while we spoken to set up
Let the
yes. It's on the Juggernaut back. That one, as you said. Oh.
There's someone logged on using YouTube to view around you, Matron.
Yes.
The feedback is affecting your audio too.
Okay.
Okay, this is much better, I think.
You can see another screen shared by
Dr. Vera.
Somebody.
I think Dr. Vera tried sharing his screen. Yes, he shared his screen.
Okay. I'm trying to retrieve my job, my work.
No problem. Once you're done, let us know.
All right.
Dr. Basi, let Dr. Ijegere continue.
No problem, sir, but your network is still sketchy. Can you hear me, sir?
Let Dr. Ijegere continue. Yeah.
Dr. Basi, can you see my slide?
Your slide is visible, but your audio is poor.
Dr. Basi.
Yes, I can hear you. Can you hear me?
Okay. No, it's Ijegere that is on now.
Yes,
I can hear you. Let
Dr. Ijegere is
Let's see how
on,
it goes.
but his audio.
So types of magnification. Basi, can you hear me?
Yes, go ahead. We can hear you.
Okay. Hello, can you hear me now?
Yes, we can. We can.
Yes, I can hear very well.
We can hear you.
Can I continue?
Please go on.
Hello.
Please go on. You can continue.
Now. So just talk about types of magnification. Yeah, types of magnification. We have relative size magnification and relative distance magnification. What this tells is
okay, we lost Dr. Vera again. I think he's having very, 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 very difficult time with his network connection. Mr. Hameje, have you gotten your work back now? You will need to put your microphone on. Your microphone is mute. Mr. Hameje, your microphone is mute. You need to put your microphone on. Mr. Hameje, your microphone is off. You need to put your microphone on.
Am I in order? Yes, I've done that. I've done that.
We can
It's
hear you
on
now.
now. Okay. All right. Okay. Let me get my work. Okay. Installation of hydrographic storm. I have to keep the work since it's still basically.
So while we wait for our speakers to get set, and we'll take some questions now, please put your questions in the chat box. The chat box is going to be used for our question and answer segment. Please let's put our questions in the chat box, and we'll take questions now while we wait for our speakers to get set. If you're watching us on YouTube, please put your questions on the chat section for YouTube. So while we also wait, Emmanuel from Microsoft is with us, and please get ready, get prepared.
Okay, thank you, Dr. Basri.
Yes, please. While we wait, you can start now. But Emmanuel, please present, and while we wait for our presenters to sort the problems out. All right.
Okay,
please.
Dr. Basri, thank you for having us here, Micronova.
Yes, please.
Can you hear me, Dr. Basri? The presentation will actually be made by the product manager, pharmacist Hilda Kenwa from Lagos. From Hilda, if you can hear me, please take over. Hello, from Hilda.
Hello, should I start now?
Yes, please go ahead, ma'am.
Yes, please go ahead. Go ahead. Okay. Go ahead.
Okay, good afternoon, consultants, doctors, all protocols duly observed. My name is Akenwa Hilda, and I'm going to be presenting on management of, hold on please. Okay. Okay, I think I should just I can manage it like this. Okay, good afternoon. My name is Akenwa Hilda, and I'm here to present on a management of glaucoma, the micropost approach. Before I go on, I'll emphasize on Micronova. We were incorporated in Nigeria in April 2010 as a specialty division of Microlabs. We began our marketing operations in February 2011. Okay, now Microlabs is our manufacturing unit based in Bangalore in India. We are not into any form of contract manufacturing. Microlabs is the same as Micronova. Micronova is Microlabs. Microlabs is just our manufacturing unit. So you can be rest assured that we will not compromise in terms of quality and efficacy. We began marketing operations in February 2011. Currently, we have over 60 registered products with NAFDAC, spanning across different therapeutic segments such as cardiology, diabetology, gastroenterology, and some anti-infectives. Our vision is to be regarded as a state-of-the-art pharmaceutical company in terms of quality and customer satisfaction. Our mission is to provide quality medicines at competitive prices anywhere in the world. So before I start my presentation, I'd just like to introduce our Misopt. It's also an anti-glaucoma. It's a combination of dozolamide and timolol, and enhancing blood flow at the same time decreasing IOP, and studies have shown that the results have been amazing. We also have our anti-infectives. We have Floboid DX. Floboid DX is our brand of ofloxacin and dexamethasone. And we also have plain ofloxacin as Floboid. We have our 4th generation fluoroquinolone, which is moxifloxacin, as is called Micromox, 0.5%. We have our anti-allergy, which is Microsol. It contains nafazoline, which is a decongestant. And it also contains chlorpheniramine maleate, which is our popular pyritin, and zinc sulfate. We have Kerob, which is our NSAID, is our brand of Flobiprofane. And we have Torolac, which is our brand of Ketorolac, all readily and available and affordable. The newest on our ophthalmic portfolio is Rapidon. Rapidon is our brand of olopatadine, 0.3%, 0.1%, I beg your pardon. Olopatadine 0.1%. And the reason and the rationale why we have chosen olopatadine is because along the cascade of allergy and inflammation, it can actually act as a mast cell stabilizer, preventing the mast cells from opening, and also as an antihistamine. Now, studies have shown that you will get good onset of action from the signs and symptoms of allergic conjunctivitis compared to other, compared to olopatadine 2%, and also compared to sodium chromoglycate. You'll get wonderful results with our Rapidon olopatadine 0.1%. And to my presentation proper, like I said, I'll be talking about Micropulse, which is our brand of Travoprost, 0.004% eye drops for the management of glaucoma. I'll begin my presentation by defining glaucoma. You know, initially glaucoma was defined as a disorder characterized by increased IOP that may cause impaired vision, ranging from slight loss to absolute blindness. Now, because of the fact that some patients will actually present with a normal IOP, yet there is evidence of glaucomatous damage. Hence the shift in the definition of glaucoma as a multifactorial optic neuropathy in which there's a characteristic acquired loss of retinal ganglion cells and atrophy of the optic nerve. Now, with this being multifactorial, you would agree with me that there's also a need to offer neuroprotection. In other words, we'll have to protect the retinal ganglion cells even when IOP is normal. We have 2 different types of glaucoma. The common ones, open angle glaucoma, angle closure glaucoma. Now, in the management of glaucoma, we need to understand that the goal is now to move beyond just IOP control, because the progression of glaucoma, like I said in the definition, appears to be multifactorial. Studies have shown that up to 30% of newly diagnosed glaucoma patients may have a normal IOP. So lowering IOP alone does not always prevent progression of visual field damage. Vascular factors without elevated IOP may lead to tissue ischemia and glaucomatous damage. Now, with all this said, there is a need for us to dual regulate. In one single preparation, we want to be able to decrease the IOP, that's addressing mechanical factors. And at the same time, we want to be able to increase ocular blood flow in order to pay attention to vascular factors in just one single preparation, knowing fully well that there is a relationship between an increased IOP and decreased ocular perfusion. Both of them, directly or indirectly, will cause apoptosis. And apoptosis is damage to the retinal ganglion cells. And like I said earlier, there will be a need for us to pay attention to neuroprotection. That will bring us to look at various classes of neuroprotectors. We have the ocular hypotensive agents, we have the blood flow enhancers, we have sodium channel blockers, glutamate inhibitors, neurotrophic factors, nitric oxide inhibitors, we have free radical scavengers, apoptosis-related protease inhibitors, we have new protein synthesis inducers, genetic modulators. Now, because we know that studies have shown that increasing IOP can also indirectly cause decreased ocular perfusion. So that has made us to offer neuroprotection by increasing blood flow to the ocular tissues. So moving on, we want to know the role of ischemia in glaucoma. Inadequate blood perfusion of the tissues deprive tissues of nutrients and oxygen, and this may lead to cell death. Ocular ischemia may be central to retinal ganglion cell death. In other words, if we are able to pay attention to vascular factors, increasing blood flow to the ocular tissues, we might just be able to offer neuroprotection to the retinal ganglion cell death, hence decreasing or managing glaucoma progression. Now, looking at glaucoma medications and OBF, their ocular blood flow, it was found out that from different techniques that was actually used, different techniques on a particular drug class, it was actually found out that the topical carbonic anhydrase inhibitors and the prostaglandins actually have an effect on ocular blood flow to the eyes. And I'll just chip in that that's where our Misopt falls into. It's a topical carbonic anhydrase inhibitor. And then prostaglandins and my micropulse is what I'll be talking about today. So you'd agree that in Micronova, we are offering dual regulation, we are offering neuroprotection, and we're also offering a win-win situation. In moving ahead, IOP control should not just be the sole aim of modern glaucoma therapy. A hypotensive agent that enhances blood flow to the eye and provides neuroprotection will be an optimal therapy because visual field loss will continue in some patients despite successful medical or surgical reduction of the intraocular pressure. We can't speculate that any anti-glaucomatous drug that lowers IOP but concomitantly reduces blood supply to the eyes implies a potential risk of optic nerve fiber ischemia, which I'm sure that we wouldn't want for our patients. So this is a rationale for you to adopt a micropulse as your prostaglandin analog choice for managing your glaucoma patients. How would we want to decrease the pressure? We either want to decrease the inflow or increase the outflow. Now, in embracing medical treatment, we are either going to use drugs to close the faucet as Misops will do, or drugs to clear the drainage as our micropulse will do. Now, the goal of any medical treatment is one, the risk of therapy should be less than the risk of no therapy. There should be long-term objective. It should have a great IOP lowering effect. It should be safe, and the patient must be able to use the therapy you're offering. There should be minimal effect on the quality of life. Having said this, the ideal drug should be suitable for daily administration. In other words, should be able to enhance compliance. It should be effective. There should be minimal side effects and then long-term safety. Now, this brings us to look at an overview of prostaglandin analogs. Prostaglandin analogs are effective in lowering the pressure inside the eye. Prostaglandin analogs are effective in lowering the pressure inside the eye, which lowers the risk of damage to the optic nerve by 25 to 30%. Prostaglandin analogs are the most frequently used medicines for glaucoma treatment, commonly as travoprost and latanoprost. And their mechanism of action, they increase the outflow of aqueous humor through the uveoscleral channel. Still looking at an overview, travoprost is a synthetic analog of the prostaglandin F2 alpha class of intraocular pressure lowering drugs used to treat ocular hypertension and glaucoma. The travoprost molecule is an ester prodrug that is hydrolyzed by corneal esterases into its active free acid form. Like I said earlier, travoprost is highly potent for the F2 alpha receptors, and they are thought to reduce IOP by increasing the outflow of aqueous humor, primarily by increasing the uveoscleral outflow. The pharmacokinetics. Travoprost is absorbed through the cornea, and the peak plasma concentration of 25 picogram per ml is reached within 30 minutes. It's moderately distributed in body tissues with plasma protein binding of 80%. Travoprost-free acid is rapidly and extensively metabolized in the kidney, the liver, the lung to inactive metabolites. They are mainly excreted via the bile, 61%, and the rest excreted by the kidneys. Micropost is indicated for the reduction of intraocular pressure in patients with open-angle glaucoma or ocular hypertension. The recommended dose is 1 drop in the affected eye once daily. The reduction in intraocular pressure starts approximately 2 hours after administration, and the maximum effect is reached after 12 hours, which signifies the fast onset of action. The side effects include conjunctival hyperemia. Now, this is typical to most prostaglandin analogs, and then it can actually be, for patients who cannot cope with it, we can actually prescribe, co-prescribe with our brand of Microsol, which contains nafazoline in order to reduce the redness. But this is typical to all prostaglandin analogs. There's iris and eyelid hyperpigmentation, eyelash changes, and there are other rare cases of iritis and macular edema. Now we'll be looking at conclusions of studies that was done comparing travoprost and other IOP lowering drug. Now the first one, travoprost acid was found to exhibit a higher binding affinity, higher potency, and higher selectivity for the FP2 alpha receptors than either members of its class, latanoprost or bimatoprost. There are 2 different concentrations, 0.0015% and 0.004%. It was found to be highly selective for its receptors, and it was found to have equal or superior efficacy in terms of lowering intraocular pressure with latanoprost, and it was superior to timolol in lowering intraocular pressure in patients with open-angle glaucoma or ocular hypertension. Now, this was another study that was done to compare latanoprost and travoprost in terms of the ocular blood flow. Now, it was found out that both travoprost and latanoprost was able to increase blood flow, but only travoprost was able to keep it constant over a 180-day period. Travoprost, the blood flow actually decreased, and for my slide earlier, it will not be good because we want to avoid optic nerve fiber ischemia. So this is another rationale to use travoprost for managing glaucoma in your glaucoma patient. Even though the recommended dosing is once daily, travoprost can lower IOP up to 84 hours after the last dose, demonstrating greater IOP control at the end of each dose compared with latanoprost. Moreover, it was found to be convenient in terms of the daily dosing, and that has made travoprost a first-line therapy for glaucoma treatment. Now, still on the comparison of latanoprost and travoprost, the percentage reduction in IOP at the end of 12 weeks was 34.7% in the travoprost group, and it was 31.3% in the latanoprost group. At the end of 12 weeks, the reduction in IOP was statistically significant as early as 6-8 weeks compared to latanoprost, and was well tolerated. So we could say that travoprost could be a favorable option for the treatment of primary open-angle glaucoma, most especially when you desire to achieve a target of 30 to 35% IOP reduction. Then you can opt for travoprost. Now, showing graphically the difference in the IOP reduction of travoprost and latanoprost. It was found out, like the slide I showed earlier, travoprost had a significant reduction in IOP, more than latanoprost. Now, looking at these values, you would think that the difference is small, but then again, studies have shown that for every 1 millimeter reduction you're able to achieve in IOP reduction, you have automatically reduced the risk of glaucoma progression by 10%. Still on comparison, we can see that the daily dosing of travoprost and latanoprost at 4 p.m., there was a statistical significant reduction in IOP compared to latanoprost. The secondary objection that was assessed in the study was the safety of the 2 study medications. Now, there was conjunctival hyperemia seen, which was the commonest ocular adverse drug reaction, 15%. It was shadowed by dry eye, 11.7%. There was burning sensation. There was itching. The percentage of patients with hyperemia in the travoprost group was 6.7%, and in the latanoprost group, it was 8.3%. At this point, I would like to introduce our micropost, which is a brand of Travoprost, 0.004% weight in volume. I would say here that the volume has been increased from 2.5 mil to 3 mil and down now to 5 mil, still at the same price. And it was reformulated without back. So I would say that our MicroPost is a back-free solution and a 5 mil pack to make your patients happy and save them the hassles of always purchasing every 3 weeks. Then we'll look at the salient features of MicroPost. Now, there's flattening of the circadian curve of intraocular pressure. Fluctuations in IOP over 24 hours are a significant risk factor for progression of glaucoma. Travoprost reduces the 24-hour high IOP fluctuations to the same range as you will see in normal eyes, although no similar studies have been done for other prostaglandin analogs. And this is what we have here represented it graphically. We can see that Travoprost has actually reduced the level of IOP fluctuations to what you will have in normal eyes, which poses a risk in the progression of glaucoma. Another salient feature of MicroPost is the long duration of action, which I call the MicroPost endurance. In clinical studies, Travoprost reduced baseline IOPs by more than 6 millimeter mercury, even 84 hours after the last dose. In other words, even if a patient misses a dose, you'll be so sure that after 84 hours after the last dose, you still have a reduction in IOP. So this is an important advantage for patients who may miss an occasional dose or who may have generally poor compliance with glaucoma medications. I would also say emphatically that we need not store Travoprost or MicroPost in a refrigerator compared to other members of the prostaglandin analogs. Now, this will also save your patient the hassles of NEPA and PHC and all of that. So storage at room temperature is just suitable for our brand of Travoprost, which is MicroPost. Now, in looking at the advantage of MicroPost as a glance summary, there's superior IOP reduction, there's flattening of the diurnal variation, there's a long duration of action, even after 84 hours from the last installation. There is sustained pulsatile ocular blood flow offering neuroprotection. There's wide temperature storage range. You can store in room temperature, not necessarily between 2 to 8 degrees Celsius. MicroPost is safe and well tolerated in patients with open angle glaucoma or ocular hypertension. Now, to conclude my presentation today, I'll say that glaucoma blindness is still too common. IOP reduction has significant effect on treatment. Progression still happens even within the statistical normal range. That's patients who have normal IOP, there's still progression of glaucomatous damage. Prostaglandin analogs are indicated as first line in the management of primary open angle glaucoma. Our Travoprost, our MicroPost stands out. With this, I would like to say thank you for your time, as prostaglandin analogs are the most effective IOP lowering agents of all topical glaucoma medications and generally our first line therapy. Now, this is taken from the World Glaucoma Association consensus statement. Thank you very much for your time as I take your questions and your doubts and
yeah, thank you very much, Hilda.
Thank you, sir.
Looking forward to meeting you in person. I've been meeting Emmanuel ever since.
Yes,
I want to thank you for MicroPost. Thankfully, MicroPost is cheap, doesn't need refrigeration, and we hope that as we start prescribing, hopefully, we'll get the same results we get with other prostaglandin analogs. Also,
yes.
another selling point for your product is the absence of benzalkonium chloride as a preservative. So let's hope we'll get good results. We're still watching. Let's see what happens. But you have a lot of pluses going for your product. It's cheap, doesn't need storage, no back preservation. So let's see what happens. Thank you very much. I hope you find something to come see us in Irrua. We know we're in the village. Just come see us.
Yes,
Who knows?
I will,
They give
Thank
you
you,
rural allowance to go back home, like some bushmeat. Thank you very much. Okay, I think Dr. Vera is back with us.
Thank you.
Dr. Vera, sir, are you with us now?
I am with you. Network is embarrassing me, but I'm with you. Thank you very much. I don't know was Mr. Hamilton able to do anything?
No, she wasn't. So I think Jegede can start.
Okay. What I will do, I'll just we are now trying to use 2 devices to meet up. So what I will do, I'll give to Jegede. He will start talking while I try to set up the other one.
Okay,
So
I would advise that I would advise you keep your video off, so that you use less bandwidth, and then you can share your screen. I think that will also help control your bandwidth use. So you can share your screen, but keep your video off in the meantime.
Yeah, we will try and do that. All right, take it. You can just
take it over to you.
Yeah, good day all. Sorry for the hitches we had. So I was just talking about the optical low vision devices. We have magnifying spectacles, hand magnifiers, stand magnifiers, telescopes, intraocular low vision aids, and other optical devices. While the non-optical devices, you have the approach magnification, lighting, contrast enhancement, increased size objects, electronic magnifiers like the CCTV, writing and communication devices.
And sorry, please, could you share your screen? Could you share your screen?
Okay.
Please share your screen.
Just share the screen.
Let me see if I can share the screen.
Hello?
Dr. Basu, let Jegede keep talking while we keep manipulating screen.
All right, sir.
Jegede, come on. Jegede continues to talk while I just be talking.
Basu, can you hear me? Hello, Basu.
You can go. You can go. Very good.
Why the non-optical devices, we have the approach magnification, lighting, contrast enhancement, and increased size objects, electronic magnifiers, writing and communication devices, and orientation and mobility low vision devices. So let's talk about the magnifying spectacles. These are high plus lenses for magnification. They are suited for near and intermediate distance. They could be monocular or binocular. There is a picture representation of it, which I will show shortly. What are the advantages of magnifying spectacles? They are hands-free. The field of view is larger when compared to other devices. Simultaneously, you can use both for near and intermediate distances. Can be given in both monocular and binocular forms. They are also more portable, cosmetically acceptable too. But the disadvantage it has is that it has spherical aberration, so the images are not perfect. Higher the power, the closer the reading distance. Close reading distance causes fatigue and unacceptable posture. It's cumbersome with patients with eccentric physician. So patients with eccentric physician will have difficulty using a magnifying spectacle. The hand magnifiers. These are indicated for spot or short time tasks in patients with field of vision reduced to 10 degrees or more. They are available in the 4 diopter to 40 diopter types. They come in 3 designs. It could be aspheric, biaspheric, or aplantic. The hand magnifier, it has a very good working distance. Accommodation is not required for the patient. For eccentric physician, some have light source, which will further enhance vision. The disadvantage it has that patient with manual it needs manual dexterity. So for patients who doesn't have a good manual dexterity, it will be difficult for them to use. They need to be held at the correct distance so that the focus will be very sharp. The stand magnifier forms a virtual image at a short distance behind the lens, so its focus is very fixed. The patient needs to place the stand magnifier on the patient needs to place the stand magnifier on the reading material and across the page to read. This is an example of the stand magnifier. So technically, it's simple to use. They are the choice with patients with tremor, arthritis, or constricted visual field. But it has a little disadvantage that the field of vision is small and too close reading posture is uncomfortable.
Okay.
we're not talking about telescope. Used to magnify distant objects, working on the principle of angular magnification. And it comes in powers of 2x to 10x. There are two types. Now the Galilean telescope or the astronomical telescope. This is an example of the picture of a telescope. The advantage is that it is the best possible low vision device for distant vision. But the disadvantage it has that there's restricted field of view. That's connected. We'll just continue with that one.
Continue with this one.
Hello. I don't see why.
I'm with you. I can hear you.
Okay.
I can hear you.
So, and it's also very expensive and costly to use. Other optical devices that we also have, we have tinted lenses, photochromic lenses, filters, and polarized lenses. These also help the patient with low vision. Other optical devices which will enhance the visual field of the patients are Fresnel prisms and hemianopic mirrors. So let's talk about the non-optical approach of magnification. We also have the approach magnification. This is a process where the patient is made to go closer to objects for magnification. Then we'll talk about illumination. Lighting is very important for the patient to have enough light, especially for glaucoma patients. So the positioning of the light to the side of the better eye and moving the light closer. All these types of positioning helps the patients a lot. Then also contrast enhancement by the use of typoscope or adjusting the visual or contrast modification of the visual environment of the patient. Also, we also try to increase the size of materials of the patients, includes enlarged clogs, then increase
Hello, Dr. Jagede, are you still with us? I think we've lost them. I think we. Okay, Mitra Hamiji, we've lost Dr.
I'm ready.
Okay, please.
Yes.
Your screen and start, please.
Okay. Are you with me? Can you see my screen?
We are with you, but we can't see your screen yet. Your screen is not shared yet.
Okay. Good morning. Okay. Can you see my screen now?
No, we can't.
No, no, I can't.
Can you see it now?
Okay, you started sharing, but we have
Yes.
we can see your screen. But we're not seeing your presentation.
Okay. Can you see my presentation now?
Yeah, it's showing now.
Yes, very good. Okay.
Good afternoon, everybody. I'm back. As I was presenting before, as I introduced myself as Mr. Hamioje, I'm presenting the nursing management of the visually challenged patients during this glaucoma week. And with my objective, the participants will be able to assist the visually challenged in achieving the activities of daily living within the hospital and social environment. And it's under the following outline: objective introduction, nursing the visually challenged in the hospital, installation of eye drop, feeding of the visually challenged, traveling with the visually challenged, and conclusion. As a way of introduction, as eye health workers, we give much attention to learning and teaching the importance of health education and prevention and treatment of eye diseases. Despite the knowledge we have and apply in caring for our patients, it is sad to say that our efforts are not successful sometimes, and we are given the responsibility and challenge of caring for our people who have to cope with visual impairment, possibly for the rest of their life. We have to learn how to cooperate and communicate with them in the hospital and social environment. This is because anybody can be visually impaired or blind. Despite the visual impairment or blindness of anybody, a lot can still be achieved when we give them practical and welcome assistance. Hence, the reason to learn nursing care for the visually impaired. When nursing the visually impaired patients, the first thing in meeting him is greeting and introduction. You meet the visually impaired, for example, you introduce yourself: I am Nurse Hamioje. I am the one that will take care of you. I'm in charge of this ward. I'm taking you around. Your bed, you are going to stay on this bed. You are on bed 3. You identify the bed of the patient. After the bed has been prepared, you put the patient on his bed. Then you introduce the roommates to the patient. Your left is Mr. John. Your right is Mr. Peter. So all of you have the same challenges. We'll be nursing you. I'll be the one nursing you this particular afternoon duty. Then you ask the patient what the patient is able to see. That's by visual acuity. You assess the patient vision. Some of them are just impaired. They can still see light perception. Some can still read some letters. Some vision are not very bad, while some are completely blind. But it's only few patients that are actually completely blind. According to the previous presenters, 80% of glaucoma patients actually stay with vision to death. But the other 20 go blind. Among these other 20, you have the low vision, that's visually impaired patients. When they come to the ward, you assess their vision, you ask the patient what assistance they will need, instead of assuming that you know their needs. You ask them. Then you also tell them, introduce the environment to them, orientate them with the environment. Don't describe anything to them by pointing fingers. Use words like you from your left, your right, in front of you, behind you. Then when attending to them, you should also explain everything about their procedure to them. You tell them, I want to instill eye drop for you. This eye drop is lavanoprost and is for your glaucoma, reduction of the IOP, so that the little vision you have can still be sustained, but that patient will cooperate. You explain the procedure, whether it's tints, Whether the eye drops things, you explain to the patient. Then when leaving the patient, after discussing with the patient, put the patient on bed or taking the patient around, whatever, you must tell the patient, goodbye, I'm done with you, I'm going to my nursing station. Or you must leave the patient without announcing it. Don't leave the patient without announcing it. Patient must know when you are leaving his bedside or leaving his room. When introducing yourself, you must be warm, you must be calm, and your greeting must be welcoming. As I've said, you oriented the patient using the bedside reference points. From your bed, you have the toilet is about 6 or 7 steps from your bed it's on your right-hand side. When you are coming out of the room, your door, you have a patient by your left, but the coming out of your room, you have to take 6 steps to the door out of your room. Then the door frame, sometimes patient you can use the door frames could be dark. That will make a color contrast. Then when the patient enters the rooms, you control the glare by adjusting the curtains or the shades as necessary. When you have talking books, you put it by the side of the patients where the patient can have access to it. As I've said before, you don't die the point when giving direction. Instead, use words like right, left, front, behind. Remember that when you are facing the patient, your left is the patient's right, and your right is the patient's left. So when giving direction, you should have that in mind. When you see a patient that is using a white cane or that is visually impaired, don't just go straight to say, let me help you. You first introduce yourself. Madam, I am Mr. Amioje. Good morning, ma. Can I be of any help to you? Patient can say yes. Where exactly are you going to? He will say, I want to see the cardiologist, or I want to do an OCT, or I'm here for my visit day. Then you know exactly where to lead the patient to. If the patient says, no, oh God, don't help me, I don't need your help, just leave me, I can see. Please respect the patient's opinion and be aware that the person may not need or want your help. Because it's not everybody that uses white cane that is totally blind. In some countries, some persons, visually impaired persons are accompanied by a guide dog. But these animals must never be distracted because they are the ones that receive the attention for the patient, for the claims. Because any distraction on the animals, you can be liable if you do that. Just as I've said, you have to speak first when talking to the patient, a visually impaired patient or a blind patient. Speak first. You can shake their hands if they offer to give you. If you say, Mr. Peter, good, how are you? Good morning. You also give back your hand to the person and say, good morning, I am nurse, so and so. Then be polite in your approach. Look at the patient face to face. Take the same position with the patient. If the patient is sitting down, sit to talk with him. If he's standing, stand to talk with him. If he's walking on the way, walk by him. Side by side. Don't be scared to use languages like words like you can see, you look at so person, you look at so issue. No, when discussing with the patient, use these words because they also have vocabularies like the sighted person. They explain noises and silences. And do not shout when you are doing that. You need, because some of them that are visually impaired have their hearing senses intact. So you don't need to shout. That noise was about somebody that just gave birth. You have people shouting. We are celebrating. Oh, congratulations. Oh, that's good. Then when there's silence everywhere, you will ask, have everybody gone home? He said, no, they have gone for a meeting. We are going for a meeting. Explain everything to the patient, but to avoid the patient being scared and being under threat. Do not invite or expect patients the patient should be able to speak. If you take that right of speaking from himself, from him or her, he will feel that he has that defect and he no longer belongs to the society of communication. So try as much as you can, even when talking to the patient, touch the patient and be sensitive to cultural values when touching him or her. As I've said before, there's no need to speak loudly to people who are blind or visually impaired, because in most cases, their hearing is just fine. Use sighted guide when walking with people for exercise. Like, this signpost shows that we should stop. We are holding on now. We are not moving now because the traffic light is on. Now the traffic light says we should go. That's why we want to move now. We are moving. They ask the patient how you can assist them. Brother, I've mentioned that before. When working with a patient, a person that is on a hallway, always refer to points of orientation as well as possible. Like, walk out of your room and turn left. The nursing station is on your right. So when working with them, you always talk to them, make them aware of where they are, and be precise when you are giving instruction. Do not give directions as I've mentioned that. It is like, it is down there. You saw a visually impaired somebody that is using a cane and is asking, where is the eye clinic? You just say, it's down that road. When you turn left, it's on the road down that way. Oh, it's just there, right there. No, it is thoughtless to do such things. So use normal tone when you are talking. Then some other patients that have visual impairment can also have hearing defects and they have mobility problem. In such patients, you apply patience and good listening skill. This is very important. You have to be patient with them. You have to apply good listening skill. And do not leave the patient without telling him or her. When you are leading a patient or guiding a patient out of the room or somewhere, and you have reason to leave the patient, let the patient rest on the wall, on the pillar, and take an excuse. I'm coming. I want to go and get something. I forgot something in the room. Let me go and get something. You can also conclude when you are done with the patient. I'm done with you. I have to leave you now. Goodbye, Mr. John. See you later in the day. When you are guiding a patient or working with a patient, do not drag the patient or walk too fast. Go at their pace. Never presume where the person wants to go. Just as I've mentioned before, always ask. Ask for details and how he or she would like to be guided. For example, a patient comes to, you saw a patient at the gate with a cane, and you just presume that this patient is going to eye clinic. Oh, man, can I help you? Let me give you a lift. You take the patient to eye clinic. I mean, the patient is going to cardiologist clinic. When you take the patient to eye clinic and drop the patient in eye clinic, the patient, what the patient wants is not in eye clinic. Because he's visually impaired doesn't mean he doesn't have other problems. Then consider the age of the patient when you are guiding or you are helping. Like this particular slide, this particular photograph, this lady is staring this old man. Wrong. This is not right. This is not how to guide a patient, a visually impaired patient. He has impaired mobility, and he's aged. So you have to consider their age. So you go at their pace. You go slowly, because it's not uncommon to see this kind of thing happening. A patient being propelled or steered at a great speed. Oga, move now, move fast. People are coming, move, Oga, move. You know, it's wrong. And if there is space, walk side by side, and always let their hand be on your arm. I will show that picture. So this particular picture shows how to guide the visually impaired. The visually impaired person's arm is on your hand. His hand is on your arm, on your forearm. Then you give space for obstacle. For example, this one, they are crossing to a supermarket or a market. You give space for obstacles and hazards. Then you describe the changing environment. We're in a marketplace. You have to be careful. Just follow behind me. Then walk in a single file, if possible, in a narrow space, or shops and offices and busy crowded areas. Then when opening a door, this you have to learn, and it's really not easy to do, but you just have to learn it slowly. When opening the door for a visually impaired patient, the partner, you are the one to open. You open towards you. First, your hand grips the door, the handle of the door, you open towards you. You open towards you or away from you, depends on how the door is fixed. If the door is open inside, you open away from you. If the door is outside, you open towards you. But you go through the door with your partner on a hinge side, on the hinge side. Don't go and follow the other side. As you are going through the hinge side, your partner is holding your arm, is going with you. As you enter the door or the room, you let your partner's hand hold grip on the hinge behind the door. Your partner will be the one to shut the door behind him, behind both of you, while you enter the room. Tell your partner when climbing stairs, steps, and slopes, you tell the partner, we are climbing upstairs. We are going upstairs now. We want to climb stairs, or we are going down the stairs. Then you give your partner time to hold on the handrail firm and decide the first step carefully. And don't double step. You will take one step at a time, and that step is one step ahead of your partner. And it has to be slowly as the stride which the partner can go. You on the last step you take slightly longer stride on the last step to allow your partner space. Then, when you are going through curves and on the road, never take risk. When approaching a curve, or slightly before taking a step, talk to the patient. We are into a curve. Now come to my right hand or come to my left side. The patient come and hold grip of your arm while you are walking at an equal distance from the curb. The patient is at your side. Talk to the patient. Take it step by step. When you, after taking first step, you pause while the patient meets up with you. When you are crossing the road, go straight with the shortest distance. Let him or her know when you are parting, when you are done with crossing with him or the company, when you are now leaving him or her after crossing the road. Ensure that he's facing where he's going to. You have asked, Madam, are you going to the hospital or you are going to eye clinic? When you have led him to the eye clinic, you have entered the corridor into the consulting room. You are now facing the consulting room. I'm going to enter and meet your doctor. I'm going, I'm leaving you. Bye-bye. The patient knows that you have left him or her, and you will not expect to meet another helper. Now, if you want to guide the patient to sit down, do not turn the patient or steer the patient to sit down. Explain the kind of seat that you want to give to the clients. Is it a cushioned chair? Is it a low chair? Is it an armchair? Tell the patient, I'm giving you a seat. This is your seat. This seat is an armchair, or it's a cushioned chair. It's a high chair. It's a low chair. It's a stool. Let the patient know what he or she is expecting. Then place your hand. Use your hand to handle his hand. Put it on top of the seat and let the patient feel down the seat. As he feels down the seat, he takes his or her seat comfortably. This is patient safety and protection. Then tell him or her to release your arm after he has taken his or her seat. This will enable your partner to judge the height of the seat and help to sit safely at his or her own pace. Now, installation of eye drop is also the needs of the patient. Maintain hand hygiene before and after eye drop installation. You check your drugs for expiration dates. You observe the nursing rights of the 8th nursing rights of drug administration, which is in another slide now. When you remove the cork of the eye drop after explaining to the patient, you ask the patient to look up to the ceiling. You pat the lower conjunctiva with your left thumb or index finger. Raise the bottle and turn it upside down towards the fornix of the conjunctiva. Allow 1 or 2 drops into the parted conjunctiva. Mop up the excesses. Ask the patient to close his eyes gently. Replace the cover of the eye drop bottle. Keep in safe and dry places in right temperature and document. These are the rights of the patient: the right drug, the right patient, the right dose. Make sure it's the right drug, the right patient, the right dose, the right time, the right route, right reason, right response, and right documentation. Then feeding is another physiological need of the patient, and this eating time can be made interesting with good assistance. First and foremost, you have to know the level of assistance the patient requires by the degree of visual impairments that the patient has. After acting tactfully, if help is required, ask patient where best to place his or her cutleries, items, or cup, wherever how he or he needs it. As shown in this photograph, don't overfill cups or glasses with hot fluids to avoid spilling or scalding of the patient. Like this photograph is overfilled and it is wrong. The level of the liquid should always be indicated to the patient, especially when it is cold. You can put the patient hand into it to know the level of the milk or liquid that you are giving to the patient. With cool liquid, make patient to feel the level of the liquid by his or her index finger inside the vessel. Then, making eating enjoyable and identifying the type of food and its position to the plate will make the patient enjoy his or her meal. The visually impaired patient may have some vision, so you make a contrast presentation of the meal. The plates, like as it is in this slide, this table mat is dark, but the plate is white, and the cutleries, they are white, and the cup. This is a good contrast. Then orientate the patient on the contrast and on how you place the cutleries. Then when you open the food, as it is here, describe it with the clock method. For example, your meat is at 12 o'clock, your peas is at 6 o'clock, your potato is at 9 o'clock, and your vegetable is at 3 o'clock. By this method, the patient can help to feed his or herself. But assuming you want to feed the patient, you can also tell the patient, you feed the patient little by little, pick from the different pieces of meal from the different varieties of the food, and give the patient little portion at a given time. Then, if it's children, you can cut the meal into a small manageable portion where the patient can tolerate or manage it. Then, after giving the patient this orientation, the patient can eat his food. You have to clean his mouth or give him table mat, arrange everything for him, make it comfortable, and clear the table. After eating, feeding physiological needs, the patient is fine. There might be need you have to travel with the patient, or the patient has issues, is visually blind, you have to travel with the patient. You need to know how to guide the patient when you are going on a journey. First and foremost, when you get to the park or to the car, you tell the patient the direction of the car, where the car is facing. Or this car is facing your front, or it's facing the north, the east, the west, depends on where you are standing. Then your seat is at the back seat. There's somebody before you in the back seat. You have to take the center seat or the right-hand seat at the back. Now you get the grip of the door just the way you open the door to enter a room. You get the grip of the door. You hand over the patient the grip, the hinge of the door to the patient's arm. Then as you open the door with the patient, you place the right hand of the patient on top of the roof of the car, where it's possible. You put the patient's hands on top of the roof of the car, and the patient slides himself into the car without hitting his head on the roof of the car or injuring himself. That's also patient safety. Then place his or other hand, yes, on the car. I've explained that. Then discuss the distance where you are traveling. For example, here to Auchi is about 45 minutes to 1 hour. We'll be traveling down for the next 1 hour. The car is filled up. We're about to move. When you move, if you have any issue on the way, why you have to stop, let the patient know that you are stopping for one or so reason, police checkpoints. So the patient will go along with you. Then in conclusion, other patients with visual impairments may have hearing defects and may have also impaired mobility. But with good approach, right attitude, patients, good listening, communication skills, as well as welcome practical assistance of the nurse can help to achieve their daily needs. Thank you very much for listening. God bless you. Thank you, Ma. So I'm done. Thank you.
Thank you.
Thank you very much, Mr. Hamilton. Are you hearing me?
Yes, I can hear you. Can't you hear me? Are you not hearing me at the time?
Thank you very much, Mr. Hamilton.
Okay.
Thank you, Dr. Basui, for standing for me when network tried to. I can hear you. I am hearing you. I was.
Okay.
Yeah. Obasu, you're still. Obasu, you're still with us, right? Okay. Thank you very much for your presentation. I also wanted to thank Dr. Basui for standing for me as at the time network. Because
I hope my network did not break. Oh,
yeah, you're hearing me, right?
Yes, I can hear.
Good. I was thanking everyone, including Dr. Basui, for standing in for me when
Hello, Dr. Veria. Can we take questions now, please? Can't hear Dr. Veria again. Maybe network challenges again have come up. Does anyone have any questions, please?
Are there questions? Okay, is Dr. Sadiq still with us?
Yes, I am.
Yeah, Dr. Sadiq. At least I have a question for you.
Okay, what is that?
Good.
Please, you can know.
Dr. Sadiq, are you still with me?
Yes, I'm with you.
Good.
I didn't hear the question.
Good. I said that quite often treating.
It's breaking actually. I can't hear it again.
It's question time. Unmute yourself and ask.
Okay, I've unmuted myself. Are you hearing me now? I'm actually using two devices. I don't know which one works better. Are you hearing me now?
Yes, I can hear you.
Good. I said treating children with glaucoma usually poses a lot of management dilemma. Now, at what stage would you really advise that you go for surgery for children with glaucoma? Bearing in mind our African condition and African situation, where surgery is seen not to be very, very successful, at what stage would you want us to operate on children, especially for children with open angle glaucoma?
Okay, you see, in children with glaucoma, that's juvenile open angle glaucoma. Actually, is a type of glaucoma that needs surgical intervention. If you see a typical juvenile open angle glaucoma, they have high pressures usually in the range of 30-35. Advanced damage, CDR 0.9.5. And usually one eye is lost. They have family history of the disease, and sometimes they are myopic. So for this kind of patients, wherever I see them, surgery is my primary intervention. Because, I mean, look at, imagine the drugs and the length of time the patient would like to take to be on drugs. So actually, surgery is my primary intervention in those category of patients that have full-blown juvenile open-angle glaucoma. However, you have some patients that you see that they don't have that kind of end-stage disease. They have mild to moderate disease. Those one you can start doing medication. If you have SLT, you can do SLT. SLT tend to be, I don't have the experience of SLT in younger people, but I know in elderly people it tend to be good. But then if you now go back to the congenital glaucoma, the surgery is the primary treatment modality. But for patients with GOAG in our hospital, all of us that are here, 3 of us, surgery is our first line of management. So I don't know if. Hello, did you hear me? Hello?
Are you typing your question?
Yeah, I heard you right. I said, for me, I rarely do glaucoma surgeries. It's rarely an alternative for me, but quite often when we are managing cases of glaucoma and my own area, I have reasons to look at it. They have a second look when we have to decide whether to go for surgery or continue medication. The other thing I found is that for children, quite often, they appear to be secondary glaucoma. I don't know what your advice is in that regards. Do you still think surgery is a good alternative? Dr. Sadiq, did you hear me? All right, is Obasu still with us? Apparently, my network is scratchy.
No, please come again. Let me see if I can hear you.
I said that when I come, for me as a retinal person, quite often, when I come across children with glaucoma, they are usually secondary glaucomas. So in that case, would you advise surgery, especially when they become intractable, when the primary cause of the raised IOP, even after treatment, does not seem to lower the pressure? Would you still advise surgery in this case?
Generally, sir, secondary glaucoma, surgery is the means of treatment of secondary glaucoma. In most of the time, if you have lens-induced glaucoma, you have to remove the lens. If you have if you have NVG, you have to do laser, and possibly you would like to do drainage devices. So most of the time, if a child had cataract surgery and later developed glaucoma, most of the time drug will not work. So most of the secondary glaucoma, they are more difficult to manage, and they are the ones that actually need active surgical intervention. You see, generally glaucoma in children is more of a surgical disease than a medical disease. Just imagine a child trying to apply his medication all the time. He's not even thinking about that. You understand? So most of the time, in majority of the time, 80 to 90% of the time, glaucoma in children is a surgical disease.
Thank you very much. I think that answers my question. Are there other questions, please? Unmute yourself. Go ahead.
Yes.
Hello.
Hello,
ma'am. Good afternoon. Your presentation was such a beautiful one. Though I'm not with the ophthalmic department, but it was a topic I saw and I felt it was something I needed to listen to. It was quite educative, I must confess. My question as regard the children, you said a lot of things on how you can direct a patient on how to walk, the different instructions. When you get to the traffic, you need to announce to the patient and all of that. How easy is this for you to carry out on the pediatric patients, the growing child?
Yes. Hello, are you with me?
Hello? Yeah.
Yes, can you hear me now?
Yeah, I can hear you well.
Yes, for a growing child, the child has a lot of potentials in him or her.
Yeah.
So yes, a growing child that is visually impaired has special schools for them. So what we do is that when we have such children, we refer them to special school, special schools, visually impaired school for children. So with that, their life from childhood to adults is made perfect. They can grow up to become a lecturer, to become whatever they want to be in life. And it also makes them independent, unlike an adult that just suddenly grow blind, that has been sighted all his life. There's a difference between what I presented now and in children. In children, most of the time that went through training or that has been blind from childhood, that has gone through training or through rehabilitation from childhood and has grown in his or her lifestyle, is already used to that kind of life, and they knows how to do everything. They are independent. They know how to do a lot for themselves, except they are entering into a new environment. If they are coming into a new environment as an adult, they must have also read so much about that environment before they got there. So it's only when they come into this new environment that you need their assistance, and just all that I have taught, so you have to put them through like that. They just need little education because they know so much about how to go about their life.
All right.
I have something to ask you,
Thank you very much.
Okay.
Maria, thank you very much. Thanks for attending. Maria, you have always been a friend of the ophthalmology department.
I'm not hearing you.
Thank you for always being there for us.
Thank you very much.
Dr. Sadiq has a question for
Metron. Actually, can you hear me?
I can hear you. I
actually want to tell one of our very close friends. I'm not surprised to join us today.
Very impressed with your presentation.
Dr. Sadiq has a question for Mr. Ahmed. So, Dr. Sadiq, can you carry on, please?
Okay, actually, I must say that I'm very, very impressed with your presentation, and it's quite educative.
Thank you, sir.
And I feel like if I will ask my chief I will tell my CMD to request for your transfer to our hospital. I think we need to do that. Honestly speaking,
we will resist vehemently.
Honestly, but then the thing is that this how we handle blind people. Is there any possibility, or I know the nature of our work, we are quite busy and all that. I don't know, Metro, if you still try to find time and teach some of the relatives that brings patients to the hospitals, those first degree relative and all that things, that would be a very good, if as you are taking, I'm jotting some points that I have noticed. So I'm thinking that with this kind of education, Metron, if some of the relative that brings blind patients, if we can have a session for them from time to time, it will really go a long way in helping them to move about with the blind patients. But you have really tried. I'm really impressed. And again, I hope you are teaching the younger ones, because the younger nurses we're having now are not the older ones that really have patients at heart.
Yes, we are unique in our departments.
Oh yeah,
my nurses are very wonderful.
I can see teamwork.
Yes, you're doing well. Yes, thank you. Thank you, I appreciate that.
Dr. Very, are you with us? I think Dr. Veria's network has acted up again. I'm not sure he's with us. And I'm not sure Dr. Obasu is.
I'm with you, ma.
No, Alika, I'm actually with you.
We're actually with you.
Hello, Dr. Alika.
Yes, sir. Are you with us?
Yeah. I'm with you. I am with you.
One of them to wait for me. Yes.
Dr. Alika, are you hearing me?
I'm at work. I do. I mean, I'm at Papa work.
Yeah, let's
Hello?
go on. Let's go on with the questions.
Yeah.
I think we are running short of time.
This Messi OBM that I'm seeing here, is that the Messi we know?
Hi.
Dr. Alika.
We have Dr. Messi Obemi.
Yes.
Hi, everyone.
Is that the Messi we know?
Good afternoon.
Good afternoon, Messi. You're welcome. Having you with us.
Very wonderful presentations.
Messi, you couldn't have slipped in like this and just escaped. In fact, when I saw the name, I was wondering whether this is the Messi I know.
It's me. Oh,
nice to have you.
thank you, guys. This is very nice. Can't complain. We're alive.
Welcome. Thanks for being a friend of the department. I've always been a friend of the department.
Thank you, guys. Good job.
Thank you very much. Are there other questions, please? Well, in the absence of any other question, I'll call on the HOD. If the HOD has anything to say before so that we can round up and go.
Everybody, with network and all those challenges from beginning to the end. Talks useful. I, for one, gained so many little nuggets that are going to be so useful to me in my practice. And for those of us who handle patients with low vision, I think it's been a really wonderful afternoon, very rich, and we want to thank in a very special way Dr. Sadiq for accepting to be a resource person in this awareness talk. We've all had to move forward despite the challenges of COVID. Normally, we would have had an outreach, would have gone out into the communities to talk to them about glaucoma and glaucoma blindness. But this time around, we've had to do it as a webinar due to the challenges of COVID. But I think despite that, at the time, I think I counted almost 50 participants. That's quite an achievement for us being in a relatively rural setting. And I thank our resource people, Dr. Basui, Dr. Sadiq, Dr. Jegede, Matrona Hamoje, and the drug presentation. I mean, it was really wonderful. It's a wonderful afternoon well spent. Thank you all for participating, and I hope that we can have a similar session sometime soon. The YouTube link will be available, so if we want to sessions at our leisure, we can do so again. Thank you to all for participating. Have a nice afternoon and happy World Glaucoma Week. Thank you, everyone. Over to you, Dr. Ray.
Yeah, thank you very much. I guess the HOD has already done the vote of thanks, but I can't help but appreciate the fact that somebody like Dr. Afusi joined us in this webinar. Enoch, our very senior colleague, was also with us. Kadri is always there with us. He was there today also. And of particular importance, I will not fail to mention this, is that one of us, a very senior citizen, Matron Isebeme, joined us again. Despite having retired from the department and from the hospital and it's out there, she still has us at heart and she still found time to join us. Matron Isebeme, thank you very much for being part of this. Jegede, it's unfortunate you couldn't finish your presentation, but I can assure you, you have already stimulated our appetite, so we'll continue to do more. Don't worry, there will be another opportunity for you to do a proper presentation. I can't acknowledge everybody enough. There's this Ibrahim Umar, is it Umaru? I know you. I think you are the one I know, and Ibrahim Sule, you may be the ones I know. And there's this Miriam Baba who was with us also. And a lot of other people that are not even in our department or even in Edo State joined us. We want to thank you for being part of it. Matron Nimaria, you're always a friend of the department. Thank you for being there. And every other person that was present. The HOD has already thanked the presenters. We can't thank you enough. Thank you for making our day. The drug rep, I'm sorry I didn't have much contact with you, but thank you. I saw some of your presentation. It was quite nice. Once again, I want to thank everyone for being part of this presentation and say that the World Glaucoma Week is not quite over, it's still on. And our OCT program in ISTH is still on, 50% discount. And once again, I say thank you for being part of the presentation and God bless you. Bye-bye.
Thank you.
Yeah, thank you very much,
You
everybody.
can unmute yourself and say something to everybody now.
Thank you very much, everybody.
Oh, thank you, ma.
Yeah.
Thank you.
Thank you, sir.
A beautiful one.
Chombola was also
Hey, network.